Hi, my name is Dr. Alon Orlev. I'm a neurosurgeon. I'm going to be talking about emergent sellar decompression today. And I'm talking from the Seattle Science Foundation, a beautiful, amazing cadaver lab that I've been working at quite often. This video is, as I said, it's an emergent sellar decompression using an endoscope. It's meant for neurosurgeons that commonly don't do these procedures, neurosurgeons that do other things and are less familiar with the endoscopic endonasal. I'm going to go through just a very basic anatomy, and it's going to have three parts to it: the nasal part, the sphenoid part, and then the intrasellar part. And that's just for urgent cases when you need to do urgent or emergent sellar decompression as a general neurosurgeon. Again, this can be done either microscopic or endoscopic. I prefer the endoscopic way, and I'll talk about the various instruments that we use and how we do this, and I hope this will be helpful. If you want a more detailed anatomical approach, then you can watch the other videos that we have online. I have a video that's called Rhinology for Neurosurgeons 1 and then 2 that details the other approaches. So for this is just an emergent sellar decompression. So we position the patient supine, and usually we would like the head extended a bit and turned over a bit towards us. When we're standing on the right side, the head will be a little over to the right. The amount of extension kind of depends on the surgeon. Some surgeons would like to have the endoscope coming in this direction, especially when you're standing back a bit. Some feel that it's more comfortable this way. Others would like to come in from the top. So that kind of determines the level of extension of the head. So we use a 4mm endoscope, and there are various brands, of course. We use a 0-degree endoscope commonly. And with the 0-degree endoscope, there's a light cable that it doesn't matter where it comes from because the endoscope is a 0 degree. So we'd like to keep the endoscope pointing up, this part of the endoscope pointing up towards the head. And again, this light cable can come from any direction that we want. We commonly would have it towards the top of the head, towards the vertex, so it's out of our way. The way we commonly work is having either somebody assist us, an ENT or a neurosurgery assistant holding the endoscope, usually with his right hand standing over here, and then the surgeon can use two instruments coming from this direction. Alternatively, you could do this single-handedly, the way most ENTs work. And you do this, and that's how I'm going to do it today. I'm holding the endoscope in my left hand. Again, this pointing up. This doesn't matter, but it will point up as well, so it's out of my way. I'll put the endoscope in, and you kind of park it on the top side of your field of view, and you kind of park it against the nostril, and you work under using your other hand with other instruments. So again, the endoscope is going to be on my left hand, and I'll use that all the time. Other than that, you usually have a defogging pad that you fill with defogging solution. That helps a lot in order to clean the endoscope. You have various suctions, and you will need a few dissectors of different kinds. It doesn't really matter, some larger and some micro dissectors, and I'll be using some of these. I'll pick one just to start with. You'll be using a drill. Usually you'll need a longer drill, and we use usually a 3 or 3.5 millimeter. You can use a cutter or a diamond, but it has to have a long shaft, of course, such as this drill. You'll be using a few Kerrison rongeurs and a few pituitary forceps and a few suctions. And that's really all you need for this urgent sellar decompression. And now I'm putting the endoscope in. And as I said, I park it on top, and I put in my instrument underneath it. In this case, I'm putting in the suction. And I slide along the floor of the nasal cavity. That's the best way to start, starting along the medial floor. And I'm on the right nostril. On the medial or left side of the patient, we have the septum. And on the right side of the patient, of the right nostril, we can see the turbinate. So this is the inferior turbinate and the middle turbinate, and behind it medial to the middle turbinate, we'll see the superior turbinate later. But for the sake of this case that we're just looking to do a sellar decompression, we're not going to deal with the turbinates too much. So and again, our goal here is to find the sphenoid os and to enlarge that into the sphenoid cavity and do that safely. So I start out, again, inferiorly and medially along the floor of the nasal cavity, and I take it all the way back, and here I'm at the nasopharynx. Okay, so I'm at the very back of the nose medially. The eustachian tubes come out here, but we're at the nasopharynx. So, and then I look up, and I see here this area over here is the floor of the nasal cavity, the nasopharynx, or, sorry, the roof of the nasopharynx, or the floor of the sphenoid sinus. And this is, and I'm going to follow that. So again, nasopharynx, and then roof of the nasopharynx, or floor of the sphenoid sinus, and I can stay medially, and as I come up in this direction, staying along the septum, medial to all these turbinates, I'm going to find eventually the sphenoid os. It's easier on the cadaver than it is on the patient. So let me show you what we do. When this overwhelms us, as it commonly does, the middle turbinate, we're going to have to deal with it. There are really two ways to deal with it. One is to resect it, and the other way is to lateralize it. So I'm going to lateralize it, but before that, I'm just going to mention how we resect it. If we want to resect it, I'm going back in there. We make a few cuts with endoscopic scissors from the front of it going posteriorly, and then we take it down a bit, and then we detach it. When we do that, its base over here, its posterior base over here may bleed, and then we use a suction cautery along where we cut. I just want to remind you, don't cut too high, because this middle turbinate will actually attach to the skull base. But in this case, I'm going to start out by just lateralizing it. When you lateralize it, you commonly hear this crunch sign of it breaking as you take it laterally. And that's what I did now. It crunches a little bit. It lateralizes pretty nicely. We can do the same thing with the inferior turbinate, so that's kind of out of our way. And once these two turbinates are out of our way, back here, we can quite nicely see the superior turbinate. The superior turbinate, as I said, was hiding medially and inferiorly to the middle turbinate. Now, let me move that a little bit out of the way. Again, that can be partially resected or just lateralized. In this case, I'm going to kind of lateralize it. It can sometimes rip a bit. But once all these lateral turbinates are lateralized, we have a nice view. And then again, I start where I know where I am, which is the floor. So again, sliding along the floor, I'm going to put in the suction, sliding along the floor, medially, septum over here. This is the roof of the nasopharynx, or the floor of the sphenoid sinus. I walk up with it, and here I find the os. Let me convince you of that. There we go. Okay, so this is the os of the sphenoid sinus, and that's what I want to reach. Enlarge the os again. Everything is coming from the inferior area in the field of view, and I find this os again. If I'm not sure, I look again. Floor of the sphenoid sinus, and then the face of it. And here we go. Here's my os. So I'm going to enlarge that. And I take some bites, and I start in the os, and I go laterally and superiorly, remembering that I have to stay only within this wall of the sphenoid sinus, because on the lateral side I have the eye, and then superiorly I'm going to have the skull base. We've already got a decent opening into the sphenoid sinus. You see that here. We're only in the right sphenoid sinus at this point. Okay, and here we're already seeing the sellar floor. And again, commonly you'll need to irrigate a bit, and you'll need to and you'll need to suction a bit in order to get rid of the debris. So now I've removed some of the some of the softer septum. I'm going to lower the mucosa from here. Okay, and my next step is going to be drilling. I'm going to drill over from this side over to the os on the contralateral side. So for that, I usually need to have a suction inside the nose, and I'll bring in the drill that we talked about. And I'm now, as I said, I'm drilling the posterior septum in order to connect the os on the left side with the os on the right. I enlarged the os on the right and got into the sphenoid sinus. I want to do that bilaterally and have it as one big cavity. When you don't see well, it's time to irrigate. Keeping your endoscope clean is something that takes a little while to get used to, and commonly you have to take it out and in. Again, don't be too close to where you're drilling because debris will fly out, and don't be as far as you can that you can still see well. And and have a suction in there. Commonly, you'd have somebody else holding the suction for you. And again, I'm just taking the posterior septum and the face of the sphenoid on the other side. I don't have to take too much of the vomer. I don't have to go too low when I'm just decompressing the sellar. Okay, I'm a bit overwhelmed by the smoke. So I'll irrigate. And at this point, things should be started to get pretty familiar for you. You see, I can see both sides. I've already taken part of the intersinus septum over here, which I've drilled out, and I can see the sellar floor pretty nicely. And is this enough of an opening? Depending on what you need to do, right? If you want to get just a sellar decompression, we can clean all this up and we can keep going to the next steps, right? Because we're basically done with the nasal section. We've opened it up. We've opened both of the osses. We've connected them. We have a nice trajectory into the sphenoid sinus. Again, if we want to go more lateral on the other side, then we'd have to take more of the floor and more of the other side. But just for the sake of decompression, we may be good enough. So I'll continue and try and clean it up, and then I can always decide later to take more laterally from this side or come in from the other side. Those are both valid options. So I think we're basically ready for the next phase. What I'm going to do first is just look through the other nostril, which having binostril exposure is important, and we can do some of the same steps. Okay, so now I'm in the other nostril, and again, what I see here is a very large middle turbinate. So I'm going to do what I did before and just kind of lateralize it. And I see the superior turbinate behind that, and I'm going to lateralize that too. In a second, I'll put in the suction, and we're going to see into what we've already done before. So again, try not to go too high, stay low. Okay, so here we go. We have the nasopharynx again. And we have, this is the os and the opening that we made. And here and I did not make it all the way to the os on the other side. So I'm going to do that now. I'm going to put in a small kerrison and I'm going to connect them. It will just give me a better opening. Again, not required for the very basic sellar decompression, but likely it's kind of better form to have binostril and it will make things easier if I can put in an instrument into both nostrils. So a lot of this is gone already from the other side, and I only have mucosa here, so it's kind of easy. Using, again, the tissue shaver would definitely do the trick here. I'm just, and you don't want to go lower, much lower than the os. So when you resect the bone, you can go a little lower than the os, but not much, unless you remove the mucosa, because the septal branch of the sphenopalatine artery travels there, and that's something that you want to avoid. You want to avoid getting into that. Okay, so here's our connection on both sides. Why don't we just take this? We'll just take the pituitary and finish this off. Again, I'm in the left nostril. Okay, here we are from the left nostril. Similar view. So that didn't take too long, and again, it's very beneficial in my opinion to have bilateral access. So this through the left nostril, and then I'm going to go back to the right nostril and use that as my main positioning for the camera. So now we're done with the first part, and we're done with the intranasal, and we opened up the osses, and we're well into the sphenoid sinus, which we're familiar with. We did not take the floor much, and that's not necessary when we just do a sellar decompression. But remember, you can't go very low, and you're kind of being pushed high. High is dangerous because that's the tuberculum and the carotids and the optics which are here. Opening up the tuberculum will likely cause a CSF leak. So if you need to go low, if you need to go to the floor, you will of the sellar cavity, then you are going to have to open up the posterior septum and the floor, the sphenoid sinus, better, which means doing more drilling here. Okay, that's very important. And remember, all my instruments are pushed high. Let me show you when I put in an instrument through the left nostril, and now I'm in my opening. You see, I'm being pushed high. I can't get low to the floor. That's okay for our case, but again, if you need to go low, you have to open up more superficially. You have to open up low over here. So now that we have that established, and we see our sphenoid cavity pretty well, we can see our OCRs bilaterally, we can see the sella, and we can do our second part, which is actually opening the sellar floor. And that will lead us into the pituitary. So I'm going to start out. There are multiple ways to do that. I'm going to start out by drilling, and again, I'm going to have to put in a suction in there, and you will likely have somebody holding a suction for you. And if not, you can park it in a way that's out of the way, and I'm going to start drilling again. I'm drilling the intersinus septum, as you see here. And when I'm done with that, I'm gonna be safer and switch to a diamond burr, because my plan now is to be able to thin the floor down, the face of the sella, but I don't want to blow through the door yet. I want to do it very systematically. So now when I'm done with the screwed intersinus septum, I'm going to irrigate, and then I'm going to change to the diamond burr. Now, if you feel that any of your instrument is limited, that you can't move it to the extent that you want to, you're limited by proximal things. Like in this case, you see I can't go left because I'm limited by the floor here. If I need to go left more or more inferiorly, as I said before, I'm going to need to take more proximal structures. But here I'm staying close to midline. Remember, you're limited by the cavernous sinus with the ICAs bilaterally, superiorly by the tuberculum, and by a potential CSF leak if you get up there. And inferiorly, you're not really limited. You can actually drill the floor pretty far down. There is the inferior intercavernous sinus, but that's usually not much of an issue. Oh, I may have broken through here. Let's see that. Now it definitely feels quite soft and it feels like I have an opening, so I'm going to have to find that and get a kerosene in there and start working on that. So let me try with my nerve hook again. There we go. Now things feel very soft, and I try and develop the epidural plane. I hope I'll be able to. Again, the cadaver things may be a little more difficult, and unfortunately I am getting also subdurally here, but I think you understand the idea is to try and find, there we go, try and find the epidural plane, dissect it, and then with a blunt instrument, and then we can open it up. That I'm doing here. Here it's just very adherent. We know the dura of these cadavers tend to fall apart in the fresh specimens, so we always have trouble getting the epidural plane, but I think on a patient it's commonly easier not to break through dura. So now I'm using the kerosene around duras and actually biting where I was before. Developing this epidural plane, and this will take me to the end of this of the second phase and onto the last part, which is actually opening the sellar floor and then decompressing it. And we'll talk about what we want to see then in a second. Remember, as you go laterally here, you're getting near the cavernous sinus, which you don't want to get into the cavernous sinus, so avoid going too laterally if you're just doing a decompression. Again, going superiorly, you have to be careful as well because that's where you're more likely to get a leak. And here I did break through dura quite a bit, and sorry about that, but again, that's kind of expected in the cadaver, and very much avoidable in the patient. So we've actually done the first and second phase, and while opening the sellar floor, we've opened also some of the very adherent dura, which is, in my hands, almost unavoidable in the cadaver. But commonly, you would be able to get an epidural plane that's pretty nice, and then see the dura, open up the dura, and then that's the third part, decompressing the pituitary gland. And we see here the pituitary gland itself. And commonly we would see a tumor, and at this point, what we would try and decompress this entire sellar area. It doesn't have to be a very big opening. It can be as small as this one. Smaller openings are safer for any of us that are less experienced. Larger openings are safer for people that are more experienced, and they require more work. And we want to remember our limitations. We're limited laterally by the cavernous sinus and the carotid, superior laterally by the optic nerves, which we see here one, superiorly by the tuberculum and potentially a CSF leak, and as I said, inferiorly and medially not by much. Once we open that up, we can use a variety of instruments in order to decompress the tumor, or the bleeding that we had in the tumor. We have to be careful not to take the gland out. Hopefully we have some sort of functioning gland, or a gland that will resume function even if it's hypofunctioning before surgery. Telling the difference between the gland and the tumor is not always easy, but it's something that we learn how to do. You can use either ring instruments in order to clean out a tumor that's in this cavity, or suctions. You can take just small micro suctions, and I'll show you how that's done. And commonly, if the tumor is soft, you can just work inside the sellar cavity, inside the pituitary cavity, with suctions, slowly removing the tumor. You work from inferiorly, reaching the floor of the sellar cavity, which we have here, and then working slowly your way up. And eventually you'll see the gland, which we see here, and you'll see the diaphragm, which will drop as well. Again, here there's no tumor. And here what you're seeing is the remnants of the dura, which I resected together with the bone, which is a bit of a limitation of doing this on a fresh cadaver. That's it. Those are the steps of doing a sellar decompression. As I said, this is a surgery that all neurosurgeons need to know how to do emergently, and I hope this helps you understand the various steps to do this safely as needed. Thank you.